Treating prostate cancer depends on many factors, including the age and the health of the patient. But let's assume for the discussion that it's a younger man, perhaps in his 50s or 60s, which is the typical patient that we diagnose prostate cancer in, who has at least a 10-year life expectancy. We look at three factors, the stage of the tumor, the grade of the tumor, and the PSA, to assign a patient into a risk category that helps tell us how aggressively the cancer needs to be treated. There are three risk categories: low risk, intermediate risk, and high risk. Low risk tumors are men who have Gleason 6 and a PSA below 10 and a normal feeling prostate. High risk tumors are men with any high grade cancer, 8 to 10, or a PSA above 20, or a large amount of cancer that can be felt on a digital rectal exam, and the intermediate risk category is in between those two. How to treat these is a little bit controversial, but there are some general guidelines. For men who have the lowest risk tumors, just small amounts, tiny amounts of grade 6 tumors with low PSAs, we know that most of those cancers are not destined to be lethal, and they probably can be watched and not treated initially. That's a strategy called active surveillance that has been gaining traction in the last decade or so. For men who have larger amounts of grade 6 cancer or grade 7 cancer, intermediate risk disease, it's generally believed that they should be treated. And there are two general options for doing that: surgery to remove the prostate, or one of several different kinds of radiation approaches. For men with high-risk disease, we know that single modality treatment with surgery or radiation is unlikely alone to cure them, and they're usually treated with combination treatment, and that can be surgery followed by radiation therapy or hormone therapy in combination with high-dose external beam radiation therapy.